Good evening, everybody. Myself, Dr. Vinu, consultant medical geneticist, take this opportunity to moderate this webinar on Anderson-Fabry disease, what is known and how to manage. Fabry disease is an inherited disorder affecting more than one organ system, yet treatable lysosomal storage disorder. We do know about the diagnostic delay, and the disease has been most times recognized after irreversible organ damage has occurred. Hence, awareness on Fabry disease is at most important for both health professionals and the public. So the month of April is celebrated as Fabry Disease Awareness Month across the world. This webinar is an initiative by the Rare Disease India Foundation to raise awareness for Fabry disease and to facilitate healthcare professionals and the greater community to improve the recognition, diagnosis, understanding, and management of Fabry disease to give patients a better chance of quality life and longer living. It is my pleasure indeed to have the distinguished personalities working in the field of rare disease on this platform. We have with us Professor Dr. Sumita Danda, who is a senior medical geneticist. We have senior consultant and nephrologist, Dr. Manish Malik, and the founder and chairman of Rare Disease India Foundation, Mr. Saurabh Singh. And I take my pleasure to introduce Mr. Saurabh Singh. He's the founder and chairperson of Rare Disease India Foundation, as we all know. He's been actively campaigning the cause of rare disease since last 8 years. He has worked generously to create awareness of rare disease in the country. He had played a very important role for making the national rare disease policy in India. He's a person who's been advocating for an effective rare disease policy. He's done his MBA from Symbiosis, Pune, and has worked for the last 14 years in various multinational companies. He's also being recognized by the Honorable Prime Minister and the government of Bihar for his certification in the NCC. He's been recognized several times for this noble cause in the field of rare disease in different platforms. Over to you, Mr. Saurabh Singh.
Good evening, everyone. I am Saurabh Singh, co-founder and chairman of Rare Diseases India Foundation, RDIF. First of all, I would like to welcome all the experts who are present here on the occasion of Fabry Awareness Month. Fabry is a rare genetic disorder. Now, I would like to thank Sanofi for supporting us for this great cause and ECMERI to become our strategic partner. I wholeheartedly welcome to all our eminent speaker, moderator, and the attendees today who are watching us and taking part in the mission to raise awareness in the country. RDIF is a patient advocacy group. It is established in 2019, and this is a non-profit organization which works for the benefits of the patients and to raise awareness about the country. Rare diseases are very few in numbers, and mostly it is genetic. Only 6 to 8% of population of India is affected with rare diseases, and 72 to 96 million people affected by rare diseases. The life of patients and the families are not as simple as the normal person of this world. There are so many challenges in rare diseases. Either there is no treatment available, or the treatment is unaffordable by an individual, which generally comes in crores. To diagnose these diseases in early stage is also a major challenge because the symptoms of these diseases generally appears after 2 to 3 years of age. Lack of awareness about rare diseases, including medical fraternity and the general public. Government does not support fully in these diseases due to its high cost and lifelong therapy. We all know that in the month of March 2021, the government of India has formulated a revised rare disease policy, but that too is not very much effective, especially for group 3 diseases, which includes lifetime treatment, but cost is very high. Families are bound to watch their person dying every day. So to discuss on these issues today, we have the rare disease experts from the renowned hospitals of India. First of all, I would like to welcome our keynote speaker, Professor Dr. Sumita Danda, Head of Department Medical Genetics from CMC Vellore, Tamil Nadu. I also welcome our eminent speaker, Dr. Manish Malik, who is Senior Consultant Nephrologist from Sir Gangaram Hospital, New Delhi. And last but not the least, I welcome our dynamic moderator of the session, Dr. Vinu N, who is Consultant Medical Genetics, Center for Human Genetics, Manipal Hospital, Bangalore. Over to you, Dr. Vinu.
Thank you, Mr. Saurabh Singh, for your great commitment and services in the field of rare disease. We now have a short video on utility of dried blood spot in the diagnostics for lysosomal storage disorder, and I request the IT team to play the video.
Lysosomal storage disorders, or LSDs, are a group of inherited metabolic diseases. Each is caused by one or more mutations that results in the deficiency or malfunction of lysosomal enzymes. Lysosomes are organelles within cells that contain multiple degradative enzymes, which serve to break down different types of biomolecules. In most LSDs, due to the reduced activity of functional enzyme, the lysosome's ability to break down complex macromolecules is impaired. These large, undigested molecules then accumulate within the cells, eventually leading to cellular and tissue damage. LSDs are progressive and over time may lead to increased disability and premature death. For these conditions, timely diagnosis is important in respect to optimal disease management. To assist with accurate diagnosis, dried blood spot (DBS) testing is available. DBS tests are easy to use, inexpensive, and reliable for testing if the following simple guidelines are followed. Firstly, all data fields on the DBS card must be completed for each patient. Dried blood spot specimens are obtained by collecting and applying whole blood to specially designed specimen collection paper. In patients over a year old, whole blood is most commonly collected through a finger prick. The blood should be applied to each circle on the DBS card. The blood should cover the whole circle. Laboratories may also accept samples collected by standard venipuncture. Blood can often be collected in EDTA tubes, but the performing laboratory should be firstly consulted. Collect venous blood in a collection tube and immediately invert the tube to mix the additive. Blood can be transferred using a pipette under the appropriate safety equipment. Hold the pipette tip above the center of a circle close to the surface but without touching it. Gradually discharge the blood and let it soak into the paper, filling the circle completely with a single application. Repeat the procedure for all remaining circles of the filter paper. Incorrect sample handling may lead to false positive results or sample rejection. Therefore, make sure the blood is properly collected. To preserve enzyme activity, samples must be dried at room temperature for at least 3 hours, away from direct heat or sunlight. To avoid cross-contamination, do not stack cards. Cover samples after they are dry. DBS specimens are classified by the International Air Transporter Association, IATA, the World Health Organization's Guidance on Regulations for the Transport of Infectious Substances, and by the International Civil Aviation Organization as a non-regulated exempt material. This makes DBS easy and safe to be shipped by regular mail when your local regulations and institutional policies for packaging and labeling are followed. DBS-based tests enable quantification of enzyme activity and easy sample collection. Positive DBS results should be confirmed as per local guidelines, often by either enzymatic activity on white blood cells from venous sample or tissue and/or genetic analysis of the suspected lysosomal storage disorder. Lysosomal storage disorders, or LSDs, are a group of inherited metabolic diseases.
We now have a keynote speaker of the day, and it is my honor to introduce Professor Dr. Sumita Danda. Madam is professor and founder head of Department of Clinical Genetics at Christian Medical College and Hospital, Vellore. She secured her MBBS and MD in medicine from GSVM Medical College, Kanpur. Subsequent to that, she was trained in medical genetics from SGPGI, Lucknow. She's received several awards. She's the recipient of the GP Enhanced Gold Medal for Best Postgraduate Student in Medicine. She's also the clinical fellow in medical genetics at Women's and Children's Hospital, Adelaide, South Australia. She's had more than 100 publications in national and international journals to her credit and several chapters in books. And she's also a life member of Indian Medical Association, Indian Society of Human Genetics, Society for Mitochondrial Research in Medicine, India, Society of Indian Academy of Medical Genetics. Her main areas of interest are dysmorphology, lysosomal storage disorders, neuromuscular disorders. I must say she's had a very instrumental role in establishing clinical genetic services in India. And also she's trained several students in clinical genetics who have fared really well and are offering services across India. Over to you, madam.
Thank you for the kind introduction, Dr. Vinu. I will start sharing my screen and go ahead with the talk. And it's an honor to be here. And I thank the organizers for this opportunity to discuss on Fabry's disease, which is a treatable lysosomal storage disorder. So I would outline the talk as introduction, the clinical features, cases, differential diagnosis and management. And I would stress more on the other features, as I know that Dr. Malik is going to talk about the nephrology aspects. So there are several synonyms for Fabry's disease. It's also due to the alpha galactosidase A deficiency and Anderson-Fabry disease, angiokeratoma corporis diffusum, angiokeratoma diffuse, and GLA deficiency. So it is a rare X-linked genetic disorder. But how often does a Fabry patient come first to a clinical geneticist? It is not very often. Why is that? Because as we can see, and the study which has been quoted here, which is a multicentric study of the clinical and genetic spectrum in 54 patients by Dr. S. Nambutri from India, Amrita Cochin, that there is a delay in the diagnosis. So although the age at the first symptom may be 5 to 10 years, out of the 54 patients, only 9 were actually detected, and 10 to 20 years, 21 were detected, and below 10 years, only 1 out of 54 were detected. So this is a genetic condition which can have a very varied presentation and can present to the general physician as well as to the pediatrician. So you can see that it's a multi-organ disease, as told to you in the introduction by Dr. Vinu. And it is a genetic disorder, means it's the X-linked disorder, and there are various symptoms. So since it's a recessive disorder, so it has got milder symptoms in the females, but major symptoms in the male. So the lysosome is the main organelle which is affected, and because of the enzyme deficiency which is produced by the GLA gene. So there are subdivisions of Fabry disease where you have a classic phenotype or type 1, and there is a later onset phenotype. So if you see or compare their classic type, it is early onset, whereas there is a renal variant and a cardiac variant, which is later onset. So they can have these angiokeratomas, acroparesthesias, hypohidrosis and hydrosis, corneal or lenticular opacities, cardiac disease, cerebrovascular disease, renal disease, and the residual enzyme level activity is less than 1% for the classical type, whereas it is more than 1% for the later onset or the type 2, the renal and the cardiac variant. So when do we suspect? It has to be suspected in males as well as females. So if there is one, especially if more than one of these features are present, that is the vascular cutaneous lesion or the angiokeratomas, the periodic crisis of severe pain in the extremities, acroparesthesias, sweat abnormalities, hypohidrosis and hydrosis, or rarely hyperhidrosis, and cornea verticillata, which is a type of corneal opacity, and lenticular opacities, unexplained left ventricular hypertrophy cardiac arrhythmias, unexplained stroke, abdominal pain, nausea, diarrhea of unknown etiology in young adulthood onset, like presenting with an irritable bowel syndrome, or renal insufficiency of unknown etiology, including unexplained proteinuria or microalbuminuria. So let's see some cases which we have seen in the past about a decade or so. And this was a 28-year-old male who was born of non-consanguineous parents and presented in 2011 with an intermittent headache since 15 years. So there were reddish small raised lesions on the abdomen, genitalia, buttocks, and history of bleeding sometimes from these. So, and also there is burning sensation in both hands and both feet, tinnitus with slight decrease in hearing, and hypohidrosis. So the family history is very important for genetic disorders, and whenever you have to bring out whether it's a genetic or a non-genetic condition, a family history is a must. So there was a family history of the mother having expired secondary to chronic renal disease. And there was nothing much in the general examination. However, the systemic examination, you can see these multiple 1 to 5 millimeter erythematous. Some are smooth, some are rough papules on the abdomen. And this was present around the umbilicus, and as well as on the back and the flank region and the thigh and genitalia. So at that time, the suspicion was not very much, and he underwent a lot of investigations. But behind the mind, there was the diagnosis of Fabry disease, which was there. Hence, a urine microscopy for Mulberry bodies was asked for, and this was positive. So you can see here the Mulberry body, which is shown in this picture. And the otherwise, most of the blood examination was normal. So because it was a multi-system involvement, so he had been seen by neurology, by ENT, by ophthalmology, cardiology, gastroenterology, renal and dental, with various complaints of headache, tingling of hands and feet, tinnitus. And because there was a suspicion of Fabry disease, an eye checkup was done, which had shown cornea verticillata. And there was no problems in the cardiac manifestation, and there was a mild hepatomegaly with normal renal functions and some dental plaques. So according to each system, he was being followed up and managed with the specific symptoms that he had. But because this was Anderson Fabry disease, and the enzyme assay was the main thing which has to be done for whenever you see angiokeratoma corporis diffusum, peripheral neuropathy, family history of renal disease. So an enzyme test was ordered, and that was actually sent to Sir Gangaram Hospital by a DBS, and it showed a low level of this enzyme alpha galactosidase, and subsequently a mutation analysis was done which showed there is a change in the GLA gene, and the amino acid tryptophan is being changed into arginine at position 95. So actually in 2012, he had been approved of enzyme replacement therapy when he had come to our clinic, and we had really struggled to get the approval. But finally, the patient did not give a consent because at that time he was managing his symptoms, and he did not think it was feasible for him to come every other week to get the ART. So that then he was continuing with the supportive therapy, and he has one brother who was normal and also a daughter. So he was lost to follow up from 2012 to 2018. And then subsequently, he landed up in the cardiology OPD because of a history of syncope and had been diagnosed with a complete heart block elsewhere. And he had been put on a permanent pacemaker. So the cardiology had seen him because of this pacemaker, and ENT review as also was done. That time he was shown to have progressing hearing loss, and because of the increasing tinnitus as well. So as compared to the previous investigations, the new development of proteinuria had happened, and the rest of the parameters were more or less normal. So this was the first case. The second case is a 14-year-old boy who was seen in 2017, again with a history of burning sensation and pain of hands and feet for 7 years, lasting for 2 to 3 days. And the child gets these episodes 2 to 3 per month and feels febrile during these episodes, and they are the symptoms are quite debilitating. It affects his daily living but resolves spontaneously. And also he had loss of consciousness 3 episodes in 2014 and 2015, and each time it was preceded by burning sensation over hands and feet. And once he had been having these the seizures with tonic limb movements. So he was evaluated elsewhere. Everything like CT, MRI, echo was normal. EEG was abnormal and suggestive of a seizure disorder, but he was not on anti-epileptics. He was having hypertension since 2015. And otherwise his um, history till 14 years had been normal. He was a normal, was born of a non-consanguineous marriage, and birth weight was 1.5, and there was no similar family history. So again on examination, there were the pinpoint angiokeratomas on the lower lip, palm, sole, chest, abdomen, dorsum of the penis, and the mucosa, nails, scalp were all normal. Again, urine microscopy had picked up Mulberry cells, and he had proteinuria with granular cast and a low level of blood alpha galactosidase, but no eye problems. The impression was of Fabry disease. And these were the small angiokeratomas, which were not in the characteristic place which we see usually at the for Fabry disease, that is the flanks and the thigh, but it was spread all over. So these are the two cases which point out that Fabry disease exists in India, and this is another evidence that which was reported by Dr. Sheila, and our center was also involved in it, where the spectrum of 54 patients has been described. So if you see the clinical presentation, it can present in early childhood or adolescence with acroparesthesia, corneal opacities, angiokeratoma, hypohidrosis. The second decade, it gradually progresses to proteinuria, and the third decade, there is renal insufficiency, and the fourth decade, complications of the cardiac and the CNS are involved in the classical type. So if you see that in the later onset or the type 2 one, they can present as young onset strokes or hemorrhages and arachnoid bleeds, cerebral venous thrombosis, carotid dissection, cognitive dysfunction, aseptic meningitis, and a CVA or a stroke-like picture. In the eyes, if you see that the characteristic lenticular opacities and also these diffuse haziness, which have these spiral streaks, are present, and they do not affect the vision, and the specific finding of cornelia verticella are specific for Fabry disease, but they can be also caused by number of drugs. Renal, I won't go into the detail, but these are the features which can happen in the kidneys. The cardiac, again, there can be sinus node dysfunctions, arrhythmias, AV blocks, and heart failure, MI, cardiomyopathies, and lower limb lymphedema. So the cardiac variant usually presents at a later age, around 40 years, with proteinuria and cardiomyopathy. Then other differentials which can be considered if you see angiokeratoma corporis diffusum is like fucosidosis, then Saki disease, then galactosialidosis, GM1 gangliosidosis, aspartyl glucosinaminuria, and beta mannosidosis. So many of them are lysosomal storage disorders. So as we saw in the video, it's easy to do a screening test by a dried blood spot, and you can also check the skin histology, but that is an invasive thing. A slit lamp examination will help you to diagnose the characteristic corneal and the lenticular findings. Urine again can be characteristic, but may not be very specific for Mulberry bodies or multi-crosses. And the definitive diagnosis is by the galactosidase levels in the plasma, leukocyte, or cultured fibroblast, the whole blood, and the DBS. And molecular analysis is a must, especially for women. So let us see at the treatment options for Fabry disease. As for any lysosomal storage disease, it can be symptom-based intervention where you have supportive care such as for paresthesias, pain, hearing aids, and disease-specific therapies such as ERT and renal transplant. But one must remember that optimal care involves both the combination of supportive and disease specific treatment and a regular follow-up by a multidisciplinary team. That is very important because no therapy is foolproof. So even with enzyme replacement, there are challenges. There are challenges with renal transplant. So a multidisciplinary approach is very much important. So as I told you that symptomatic management, which happened for our patient also when he went to neurology with paresthesias. So carbamazepine, gabapentin, phenytoin, and opiates are tried. Then for the angiokeratomas, you can have the ablative or the vascular laser therapy. So aspirin may help to reduce the risk of stroke. ACE inhibitors if proteinuria is present, dialysis or renal transplant, and conventional management for arrhythmias such as a pacemaker, which happened for our case. Then the specific enzyme replacement therapy, the two types which are available, one is the Fabrazyme and the Replagal, which are given at the Fabrazyme at 1 mg per kg every other week and 0.2 mg per kg every other week. So even the women may need these sort of a treatment because it can become troublesome. So there is also a prevention of secondary complications for renovascular disease, ischemic heart disease, CVAs as for the general population because they are at an increased risk. An annual or more frequent assessment of renal function, cardiology, audiology evaluations has to be incorporated. and substances such as smoking, alcohol has to be avoided, and one must evaluate the relatives at risk after careful family history tracking, a 3-generation pedigree. So early identification can be done, because the most crucial point is to identify early and treat early. So since it is a genetic disorders, therefore genetic counseling has a major role. It is inherited in an X-linked manner, and in a family with one or more with more than one affected individual, the mother of the affected male will be an obligate carrier or a heterozygote, and if one male in the family is affected, his mother is likely heterozygous, and or there may be a de novo pathogenic variant as well. So if a heterozygous female is present, then there is a 50% chance of transmitting this pathogenic variant in each pregnancy, and affected male will transmit his pathogenic variant to all his daughters. So an affected male will have 100%, all the daughters will be carriers. So for our first case also, since he has a daughter, therefore definitely she will be a carrier. So carrier testing at risk relatives and prenatal testing for pregnancies is possible if a pathogenic variant in the family is known. So genetic counseling, prenatal diagnosis, surveillance, all this matter in management of this disease. So the prognosis before ERT, the renal compromise used to happen around 4th to 5th decade and end stage renal failure. However, with ERT, it really improves the survival and prevents long-term complication as well as alleviating pain. But remember, supportive management is required, and ERT also can be challenging because there is a separate inflammation which is going on in all the organs involved by Fabry's, and that itself can create a lot of other problems. So assessment and monitoring of pediatric children are have a different protocol, whereas for adults there is a different protocol which has to be followed. So with this, I would like to just summarize that identifying Fabry disease in the presence of one or more typical multisystemic clinical features, it can present in childhood and adults, males earlier and severer, while females can be later and a milder type. So be aware of the atypical variants like vague symptoms of headache, paresthesia, and high suspicion is needed, where the initial workup is negative, and simple investigations like urine microscopy for mulberry cells, bodies, and slit lamp examination may be used for screening. And in the recent years with DBS, which is free of cost provided by Sanofi, it can be used for enzyme assay and early diagnosis. However, the confirmation by molecular testing and venous blood or the plasma enzyme levels may have to be achieved to know what is the type or what is the amount of deficiency. One must remember that enzyme levels may be normal in women, so has to depend on the family history and molecular testing. And early ERT can delay the onset of major systemic involvement and give relief. So thank you very much for this, and I would be happy to take questions.
Thank you so much, madam, for helping us understand the important highlights of Fabry disease and especially the practical aspects from your vast clinical experience. So we now have our next speaker, Dr. Manish Malik. And being an alumni of SGRH, Sir Gangaram Hospital, New Delhi, I take this pride to introduce Sir. Dr. Manish Malik is the Director of Dialysis Unit, and Vice Chairman of Department of Nephrology, Institute of Renal Science, Sir Gangaram Hospital, New Delhi. He's a gold medalist in MBBS. He's done his MD and subsequently DNB in nephrology. He has more than 25 years of experience in the field of nephrology and transplant. He's a designated teacher and thesis guide for DNP in nephrology. He's been honored as Shining Nephro Star by the Times Group in March 2021. He has numerous publications to his credit in both national and international journals. He's been actively promoting the cause of organ donation and early prevention of kidney disease in India. Over to you, sir.
Thank you, Dr. Veenu, for such a nice introduction. And I would want to thank Saurabh first of all, for inviting me for this important agenda. I should thank him that we as physicians, I would call myself, and not a nephrologist, do not even think about rare diseases. We are so busy with our practice that somehow we want to do the run-of-the-mill stuff, the stuff in which we don't have to apply our mind and still keep earning lots of money. Because of Saurabh and his organization, I actually read a bit about Fabry's disease, and I am at least a bit more learned about this important disease. And thank you, Professor Sumita Danda, for such a lucid presentation of such a difficult problem. You have actually made my job very simple, and I will be restricting myself to kidney and Fabry's disease. So with your permission, I would now want to start my talk.
Yes, sir.
I am trying to change my slides. Just give me a second. I'll again share my screen. I'm not, yeah, I think I'll be able to share my slides now. Yeah. So this is what is Fabry's disease for me. F for febrile episodes, A for alpha galactosidase A deficiency or angiokeratomas, B for burning sensation in boys, R for renal involvement, Y for young death, and S for sphingolipidosis. Madam has already told us the genetic inheritance pattern of how heterozygous females and heterozygous males and all behave. So I don't want to repeat it here. So as we know that the GLA gene mutation ends up into a multi-organ, multi-system disease. The heart, the ears, the nervous system, the GI, sweating, pain, eye, skin are all involved. I will restrict myself to the kidneys. So the GL3 accumulates in all types of kidney cells, and the deposits increase with disease progression, and the proximal tubule is less affected due to constant renewal of its cells, but it is these cells which, when appear in the urine, give the classical appearance which Dr. Danda talked about of the urine examination. So this is the pathogenesis of the renal involvement. So GB3 accumulates in lysozymes. Lysozyme function is reduced. Secondary effects occur on cellular function, autophagy, reduction in mitochondrial energy production, apoptosis, leading to proteinuria, and then finally renal failure. Also, the accumulation causes cellular proliferation, vascular proliferation, and further renal failure. So as ma'am mentioned, proteinuria begins in teenage years, which is the initial presentation, followed by decline in GFR and end-stage renal disease, which we now call CKD stage 5 by 40 to 50 years of age. Classically, progressive decline in renal function leading to dialysis appears in 50% of male patients and 20% of female patients. Besides the classic type, milder and late onset forms of Fabry disease have been described as atypical variants. They are characterized by non-specific symptoms and or involvement of single organs, maybe the cardiac variant or the renal variant. This was three studies which were published, which studied the prevalence of Fabry's disease in chronic kidney disease patients who are not on dialysis. So one is the Turkman study, which is called the Turk-Fab study, in which 313 patients of chronic kidney disease, which did not have a known cause, so which is nowadays called CKD-U, was screened by enzymatic assay and then confirmed by DNA. And a total of 3 patients were found to have Fabry's disease. And when their families were assessed further, so 8 more were found to have Fabry's. So this screening process showed us 11 patients. So with a prevalence of 0.95 in CKD, the mean GFR at the time of screening was 87 and proteinuria was 0.26 gram per gram, which means that the screening actually diagnosed Fabry's disease in an earlier age group, earlier stage of disease, where probably treatment could control. The study mentioned as T2 or the second study was a multicentric study done in Turkey. Overall, 1,453 patients were screened by the direct blood spot test for enzymatic assay. It was surprising that 10% of patients were found to have subnormal levels of galactosidase A, but after DNA test, only 3 patients were found to have confirmed Fabry's disease. So it is mentioned that screening of CKD-U, that is chronic kidney disease of unknown etiology, may be an efficient and cost-effective method of diagnosing Fabry's disease early and treating them, and thus limiting the potential cost and morbidity and mortality if these patients land up on dialysis. The glomerular manifestations are similar to those of diabetic nephropathy. They begin with hyperfiltration, followed by increasing proteinuria and progressive decline in GFR. The tubular manifestation could be isocynuria, which is inability to concentrate urine, distal RTA, or maybe Fanconi syndrome. These may be accompanied by excision of tubular lesion markers, such as alpha-1 microglobulin and retinol binding protein in the urine. Podocyte involvement is classical, and you may have podocytes in the urine, which is called podocyturia, and the end result is glomerulosclerosis. Endothelial cells may be involved, which contribute to development of fibrosis through luminal obstruction and ischemia.
I think there's a technical snag. I request Mr. Uday and Bashir from IT team to kindly reconnect.
Ma'am, power.
Yeah, there has been a power outage in Dimapur. I'm actually in Dimapur. So just give me a second to connect back with the system.
Sure, sir. We're very, very happy to get reconnected.
Just a second. The power seems to have come back. I was actually in Dimapur for a nephrology patient camp and some lectures. So I will be getting back soon.
Sure, sir.
Just give me a second.
So do you want us to project the slides?
But then I will have to mail them to you. Uh, yes. Am I back?
Yes, sir, your slides are visible.
Yeah. Sorry for the interruption. Yeah.
I think the screen is frozen. Dr. Malik, would you want to reconnect?
I think sir's internet connection is poor now.
So the IT team, can you help us to project the slides? Just get in touch with him. Yeah.
We don't have slides, ma'am. Sir has checked already before the uh, meeting.
Yeah, just talk to Dr. Malik. He's just connecting in 1 minute.
Yeah. Sorry for that again. Am I audible?
Yes, sir, you're audible and your slides are visible.
Yeah, thank you. So normally Fabry is characterized by a low blood pressure because of cardiac and autonomic dysfunction. But if the blood pressure starts rising in a case of Fabry's, then one should suspect that the renal involvement may have begun and CKD may now be progressive. This is the urine microscopy picture which ma'am was mentioning about. So in phase contrast microscopy, one can see the fat droplets, and polarized light shows this multi-source appearance. Again, these are the Mulberry cells and the Mulberry bodies. So Mulberry cells are the proximal tubular cells which have been shed into the urine. This is the classical radiological finding as seen in either the intravenous urogram or a contrast MRI, which shows a normal collecting system with prominent parapelvic cysts. Whenever you come across a patient who has a disease of the kidney, you would want to biopsy them. So what are the indications of kidney biopsy in a known Fabry's disease patient with renal involvement? One, to assess the degree of glomerulonephrosis and interstitial damage. To detect and quantify GL3 deposits in a patient who has proteinuria but normal renal function. If there's an atypical presentation means that they have microscopic hematuria. One, if there is a rapid progression in the kidney disease. To rule out other diseases, and for suspected or confirmed antibodies against enzymes, to evaluate response to the enzyme replacement therapy. This is what the histopathology looks like. This is the light microscopy. The figure A is an H&E stain, whereas B to E are Mason trichome. So these show us these intracellular vacuolar deposits. In T is the tubular cell, P is the podocyte, and F is an showing a spontaneous fluorescence because of the GL3 accumulation in both the podocytes and the tubular cells. This is a special stain called toluidine blue. So these deposits have a dark blue appearance in this stain because they pick up this stain, and this is visible in the podocytes in the arterioles, in the glomeruli, in almost all the components of the kidney. This is the electron microscopy, which shows the classical accumulation in the podocytes, which is P. If you look at the figure C, you find that the dark arrow, the black arrow, shows that there has been a loss of podocyte foot processes, which is called podocyte foot process effacement. And if you look at the picture D, the D is an electron microscopy picture in high power, which shows the typical microlamellar arrangement of these deposits. What are the differential diagnoses? So cytoplasmic inclusion, similar to Fabry's inclusions, can also be seen in iatrogenic phospholipidosis secondary to amphophilic drugs like chloroquine, amiodarone, and hydroxychloroquine. However, inclusions in these conditions appear different from Fabry's inclusion by electron microscopy. So if there's any doubt, an electron microscopy can cleanse the diagnosis. Conventionally, nowadays, when we do a kidney biopsy, we take tissues electron microscopy also in all our cases, which has been a recent change in our policy. This is how you screen patients. So patients with renal manifestations without a known cause, having either proteinuria or chronic renal failure. In males, you can start off by doing the enzyme activity, and if it is low, then you do a GLA gene mutation, as done it was on the Turkish study. In females, you are supposed to begin with the GLA gene mutation, and the enzyme activity assessment may be false. Treatment, the treatment is similar to any proteinuric renal disease, which begins by the RAS blockade using either the ACE inhibitors or the ARBs, and the goal is to achieve albuminuria levels 1 degree less than what is at baseline. So if the baseline was 30 to 300 milligram per gram, which is what we call microalbuminuria, you want it down to less than 30 milligram per gram. And if it is an ACR is more than 300 milligram per gram, which is A3 level in the KDIGO classification, then you want it to be less than 300. The BP control targets have to be stringent with a systolic BP of less than 130 and a diastolic BP of less than 80 millimeters of mercury. Enzyme replacement therapy, ma'am has talked about. Studies have suggested that kidney disease progression is attenuated in patients who start enzyme replacement therapy at a younger age and with preserved kidney function at baseline. Adults are at a risk of progressive loss of GFR despite enzyme replacement therapy if they have a gross proteinuria. Patients who have end-stage kidney disease may be considered for enzyme replacement therapy on an individual basis, particularly for the non-renal symptoms like severe neuropathic pain or GI symptoms. The potential benefits of ERT and ESKD are supported by limited evidence and should be weighed against the cost and burden of long-term therapy. Coming to monitoring of enzyme replacement therapy, routinely, I suppose, one suggests clinical evaluation, routine chemistries, and complete blood count every 6 to 12 months. But patients with a kidney disease should have an add-on estimation of the GFR and a urine to protein to creatinine ratio every 3 months or so. And the goal of the therapy is to limit the eGFR decline to the normal age-related decline in GFR, which is approximately 0.75 ml per minute per year after the age of 40 years. But this may not be possible because the disease is very progressive. Coming to renal replacement therapy in patients who have reached end-stage kidney disease, the survival of patients on dialysis with Fabry disease in ESRD is poor than controls. A 3-year survival has been shown to be 60% in Europe compared with 63% in the USA. There is no support that the use of either hemodialysis or peritoneal dialysis is better. So the Fabry's disease does not change the choice of dialysis modality. Transplantation is definitely the treatment of choice for ESRD due to Fabry's disease. But there is no evidence that kidney transplantation leads to improvement in any of the clinical manifestation related to the other affected organ systems. The result of renal transplantation in patient with Fabry disease are excellent. The 5-year graft survival has been reported to be 74%, which is superior to ESRD due to other causes, which is 69%. Patient survival at 5 years was slightly lower than that of a matched cohort, which is 81% versus 90%. So Fabry disease may not be a cause of graft failure, but it can be a cause of loss of life in these patients. Coming to a very important aspect which these patients would want to discuss is the recurrent disease after kidney transplantation. Generally, Fabry's kidney disease does not reoccur in the allograft kidney, but some transplant recipients have deposition of GB3 within vascular endothelial cells, but without compromise to the graft function. These cells are likely of the recipient origin, which have been transplanted with the transplanted organ. One would want to talk of certain novel biomarkers because nephrology, there's a move towards getting novel biomarkers which could help diagnose kidney disease early. So as we saw that this disease involves podocytes, tubular cells, endothelial cells and mesangial cells. So you want to have markers which could help you diagnose the disease early. So there could be markers of the immune response like RANTES. It could be markers of angiogenesis like VEGF. It could be markers of ECM turnover like fibronectin or typhocollagen. It could be markers of fibrosis like TGF-1 beta or uromodulin. It could be markers of apoptosis like caspase-6-9, and it will be markers of renal damage like podocin, prosaposin, prostaglandin, etc. But these are still in the experimental stage, and none of them is still approved for clinical use. So April is Fabry's International Awareness Month. At least one more person is aware of Fabry's, which is me. Thanks to all of you. So thank you so much. That brings me to the end of my talk. Over to Vinu.
Thank you so much, sir, for that informative talk on renal aspects of Fabry disease. Indeed, that was a very updated information, and you very well covered bench to bedside aspects of managing kidney and Fabry disease. So I think we are very happy to take, if at all, if there are any questions. So now we come to the end of this session and would request Mr. Saurabh Singh to conclude the session. Thank you. Over to you, Mr. Saurabh Singh.
I would like to thank all the respected speakers who delivered their marvelous talks on Fabry disease today on occasion of Fabry Awareness Month. I'm sure this session has increased our knowledge about rare diseases and also played a very important role in awareness. It would also have sensitized the decision makers and the policy makers to rethink about the national rare disease policy. Once again, I would like to thank our keynote speaker, moderator, audience, and the patients who are watching us now. Thank you. Thank you so much.
Thank you.
Thank you.
Thank you, Saurabh. Thank you, ma'am. Bye-bye. Good night.
Bye.
Good night.
Have a nice weekend.
Thank
Thank
you.
you.